Chandler. I'm the Director of Health and Human Services for Mendocino County. It's my pleasure to turn this over to Supervisor Carrie Brown to provide the opening remarks this evening.
Thank you very much, Tammy. The Mendocino County Board of Supervisors first committed to the Stepping Up initiative in June 2015 through adopting a resolution in partnership with the National Association of Counties and the California State Association of Counties. The resolution commitments included convening diverse teams of leaders and decision makers from multiple agencies committed to safety, reducing the number of people with mental illness in the jails. Collecting data, assessing individual needs in order to better identify adults with mental illness entering the Mendocino County Jail. Use data from both our behavioral health systems and our justice system, including the jail, probation department, and courts, and guide decision-making at the system, program, and individual levels. Identify state and local policy, funding barriers to minimizing contact with the justice system and providing treatment and supports in the community. Develop a plan with measurable outcomes that draws on jail assessment, data, and the examination of available treatment and services. Implement research-based approaches that advance the plan. Create a process to track progress using data and information systems and to report on successes. I want to thank the local team of leaders, they have been great, that have come together to assess our data and develop a local plan. I especially want to thank our local chapter of the National Alliance on Mental Illness for hosting this event today. Our board agrees with NAMI that recovery, resiliency, and support are essential to improving the quality of life for individuals affected by mental illness, and that getting people with mental illness out of jail and into treatment is a top priority. The Stepping Up initiative calls on counties to establish processes to systematically identify people who have serious mental illnesses who enter the jail. The goal is to have every county collect accurate, accessible data on those individuals because of the presence of serious mental illness in jails, and namely is 3 to 6 times higher than that of the general population, which is pretty amazing. A recent data poll in Mendocino County's jail showed that of 279 inmates, 30 of the 279 inmates have a serious mental illness. 104 of the 279 were on psychiatric medications. Average lengths of stay for those with mental illness was 156 days. 14 individuals are going through the competency to stand trial process, and 8 individuals are placed at state hospitals for incompetent to stand trial. Mendocino County is committed to a community-based approach to enhance and expand the treatment of mental illness and substance use disorders. The Board of Supervisors is proud to have supported the Mendocino initiative and how that will be used to enhance further mental health services in Mendocino County. We're also looking at a new jail unit that will provide better confinement and services for inmates with mental health issues. Bottom line, our commitment is strong countywide. All have been touched by mental illness in our own families, those of friends and neighbors, or by an incident in our lives. We do look forward to your participation this evening as we look to new ways to reduce the number of people with mental illnesses in jail and ensure an appropriate level of care for each and every one of those individuals. So the next person coming up is Janine. I couldn't remember. Thank you for the sign language. Dr. Miller, you're up next.
Good evening, my name is Dr. Janine Miller and I am the Behavioral Health Director for Mendocino County. I first want to take a moment to recognize our Stepping Up Committee for Mendocino County, so I'm going to go ahead and read off the names of the individuals who are part of the Mendocino County Stepping Up Committee. So we have Supervisor Carrie Brown, CEO Carmel Angelo, Judge Ann Mormon, Kim Turner, who is the court CEO, Tom Allen, our sheriff, Tim Pierce, our jail commander, Katie Ford with probation, Rebecca Craig, a consultant with the county, Beth Norman with the district attorney's office, Dr. Gary Pace, our public health officer, Jan McGordy with our behavioral health advisory board, Donna, did I say it right?
You did it earlier.
I know, I was asking. You might not know who you are if I say it right. With the National Alliance on Mental Illness, Tim Schrader with Redwood Quality Management Company, Mary LeClaire with the Public Defender's Office, Tammy Moss Chandler, our Health and Human Services Agency Director, Randy Smith, our Substance Use Disorders Treatment Manager, myself, Behavioral Health Director, and who I didn't mention last time, but I do want to mention this time, our support services for our Stepping Up, that we couldn't do it without Dustin Thompson, who has been our support for our Stepping Up committee, so I definitely wanted to add that in. So I'm going to give you a quick overview of specialty mental health services within Mendocino County. Mental health services are often get very confusing when we talk about the type of services, specifically when it comes to mental health. So mental health through the county is called a mental health plan. We have a contract with the Department of Health Care Services to provide specialty mental health services to the individuals within Mendocino County who have Medi-Cal and need the medical necessity for specialty mental health services. Sometimes when we really talk about special mental health, it gets easier to show it as we have your general services. It's like going to the doctor. You would go to your general practitioner for most things, but if you have a special condition, you would go to a specialist. Your special mental health services are your specialists. We see the most severe mentally ill, and that's who we serve as long as they have Medi-Cal or are indigent within our community. So we have a contract with the state to provide those services as long as the individual meets the state's requirement under Title IX for Medi-Cal and meets the functional impairment that's required. And Medi-Cal looks at what we can bill for. One, you have to have a diagnosis that meets the mental health DSM-5 diagnosis. You then have to have a functional impairment that impacts your ability to function within your daily life functions. Within Mendocino County, we have a unique system in that the county has contracted out services with an administrative service organization, Redwood Quality Management Company. Redwood Quality Management Company then contracts with sub-providers to provide your outpatient specialty mental health services. The additional service you'll hear within the mental health system for the county plan is Mental Health Services Act. The Mental Health Services Act is a 1% tax on the incomes of $1 million or more. These funds are services that support to promote recovery and wellness for adults and to promote resiliency for children and youth. Within MHSA, while it has a little broader ability to spend the dollars, it still has its requirements of what we can and can't spend that dollars on. One of the categories, prevention and earlier intervention, you'll hear about with the Mental Health Services Act over the last year has got very stringent on which areas we can spend prevention and early intervention dollars, and we have categories in which we can spend those dollars. I also want to touch on substance use disorders treatment because it is a part of behavioral health and recovery, and it's a risk factor for recidivism within the jail system, within mental health, because we have a lot of co-occurring and within Mendocino County itself. The county does provide substance use disorders treatment. We have locations in Village, Ukiah, and Fort Bragg. We provide assessment, treatment planning, individual counseling, group counseling, crisis counseling, and discharge planning. We have multiple programs within substance use disorder treatment. We have adolescent prevention and treatment. We have adolescent counselors that are in the schools providing prevention and intervention. We have a counselor at New Beginning that provides treatment services specifically. We have adult drug court, family dependency drug court, pretrial diversion, which was known before as drug diversion, jail-based treatment, outpatient treatment, perinatal treatment, and then we also do a lot of education and training that is on both sides of the house, both within mental health and substance use disorders treatment. Some of the supplemental mental health services and SUDT services I just wanted to touch on really quick. As you know, we opened the Willow Terrace Housing Project here in Ukiah on Lobby Street. It is a 38 apartment complex. One of those units will be used for a manager, on-site manager at all times. We will have 37 units that will be rented out to individuals that have a serious mental illness, are at risk of homelessness, or are homeless. And we had a grand opening in April for that, and we are waiting. We are hearing anytime after May 20th, we'll be able to start moving individuals in, so we're really excited about that. We also have our innovation project in Round Valley. This is a focus with the Round Valley Tribal Health to create crisis respite and crisis services within the Round Valley area, and it's really provided by the Round Valley Tribal Health. We have full-service partnerships under our mental health services plan. We have assisted outpatient treatment, which some of you might know as Laura's Law. We did implement Laura's Law within Mendocino County, but we do call it assisted outpatient treatment. We conducted 2 crisis intervention trainings this year with law enforcement and first responders. We plan to have more coming. We have mobile outreach and prevention services. Those are in our outlying areas. We have 3 teams. We have one that serves the North County, one that serves the South Coast, and one within our Anderson Valley Denver area. We've also implemented the whole person care grant within Mendocino County. We have a new discharge planner in our jail. That person will be working with anybody who comes into custody, screening to see whether or not they have a mental health issue, a substance use issue, and making sure upon discharge that they have their medical benefits and are connected for treatment. We also implemented in the last year jail-based substance use disorders treatment. We did not have jail substance use treatment within the county jail. In the last year and a half, we have implemented those services and now have substance use treatment within the services within the county system of county jail. We also have the behavioral health board. If anyone is not familiar with that, we have a that really focused on mental health and substance use. So we do have mental health court, which has been in Mendocino County since 2013. Some new and exciting things on the horizon for behavioral health. No place like Home Grant will allow us to look for more housing and have dollars to put towards more additional housing for those with special mental health conditions. The drug Medi-Cal waiver, which is to expand drug Medi-Cal services within our community, and obviously Medicare fee. Lastly, I just wanted to wrap up with an explanation. As we always talk about county mental health services, we only serve the severe population. There's a lot of questions on where does the mild to moderate and the private insured get services. So that's usually if you're a private insured client, you're going to get services through your private insurance, and they're going to hook you up with a provider that accepts their private insurance. For those that have Medi-Cal and are within the mild to moderate population, they usually go through the Beacon system of care, which is connected to Partnership Health Plan in California. And they usually have private providers or the federally qualified clinics within the county that offer those services. And so next, I want to introduce our CEO, Carmel.
Okay, well, welcome everyone. We're really glad to see you all here tonight. We're very happy actually to be bringing these stepping up sessions to Ukiah and also to Fort Bragg tomorrow. So usually we do so much that's Ukiah centric. So to actually be able to have these on the coast tomorrow is really something we're very happy to do. So with this, I would like to recognize some of the people that are in the room. As Supervisor Brown said, maybe it was Tammy, a small but mighty group, and that's for sure. So, first of all, we know we have the chair of our board of supervisors, Supervisor Carrie Brown here, and we also have Supervisor John McCown, and we have 2 of our Ukiah councilmen here, Jim Brown and Wanda Roscoe. So, thank you very much for joining us this evening. You know, we couldn't do this without the partnership with NAMI. So, I really want to thank Donna Muschetti and Jan McGordy for all the work that they did in getting us to where we are today. Okay, so I have the pleasure of introducing our 2 speakers. So I'm going to tell you a little bit about them. Our first speaker is Farrah McDade Ting, and our second speaker is Elizabeth Siggins. Farrah will come up first. Farah serves as the legislative representative for health and behavioral health with the California State Association of Counties. And for those of you that don't know, that's our statewide association, CSAC. And CSAC represents all 58 counties in the state, and they work not only for the large metropolitan counties, but also for small rural counties like ours. And they advocate for our efforts. And when we have a problem, we call CSAC, and they assist us. So they are really, really a benefit to us. So thank you, and Farah, thank you for being here. Farah specializes in California health and behavioral health services that are administered by counties and have an impact on counties, and has done this since 2007. Prior to 2007, Farah served as a CSAC legislative analyst on a variety of issues, including labor relations, agriculture and natural resources, transportation and housing, and Indian gaming issues. She began her county career at CSAC in 2001, serving on the public affairs side of the organization as a communications analyst. And before coming to CSAC, Farah was an assistant editor at the California Journal, a nonpartisan government and politics-focused monthly magazine in Sacramento. Farah earned a bachelor's degree in government and journalism and graduated cum laude from California State University, Sacramento in 1999. She lives in Sacramento with her husband and 2 children, and actually enjoys traveling to the different counties in the state, usually on work. Sometimes brings her family and makes a vacation out of it. Our next speaker is Elizabeth, and I'll tell you about Elizabeth now before Farah comes up. Elizabeth Siggins is the consultant on a number of criminal justice reform initiatives in California. She has worked in the criminal justice field for over 20 years in both government and community-based organizations. She was the director of rehabilitative programs at the California Department of Corrections and Rehabilitation, where she oversaw the rehabilitative programs in over 30 state prisons, as well as the reentry programs for those being released from prison. Some of her current consulting projects include working with the Council of State Governments Justice Center on the National Stepping Up Initiative to reduce the number of people with mental illness in our jails. Also with the Chief Probation Officers of California on the continuum of care reform, and with Californians for Safety and Justice on their blueprint for shared safety. Elizabeth previously worked with the California State Senate and the Office of the Inspector General. So please assist me in welcoming Farah first.
Good evening. Thank you. It's such a pleasure to be here. As Carmel mentioned, I'm Farah McDade-Ting. I work for the California State Association of Counties, which is a really long name. We usually use the acronym CSAC. We represent all 58 counties in California. What that means is we try to figure out the common interests between Los Angeles County, which is larger than most of the states in the United States, and Little Alpine County, which has 1,000 people and everybody in between. So it's a challenge, but a really good challenge, and something that keeps us very, very busy in Sacramento. I work on health and behavioral health issues, and I'm just so pleased to see people here from the community tonight on this important issue. I want to thank Mendocino County for not only inviting me and giving me the opportunity to hear some of the input from the community, but also for their hospitality today. In Sacramento, we work with the legislature. CSAC and others work with the legislature on a daily basis, as well as the new governor's administration. Tomorrow is supposed to be a pretty big day because Governor Newsom will release his May revised budget, which means the budget that the spending plan he envisions for the state in the coming year. And right now, California is doing quite well, which is great news. The revenues are good, and we're in a time where this new governor can think of some new ideas and try some new things. So we're really excited about that. But we're also concerned about the future, potentially recessions and other issues that can come up, as well as what some of the ideas that this new governor may have and how we actually implement them at the county level. As many of the county folks and the city folks know, sometimes we'll hatch a plan in Sacramento that maybe just doesn't work in your community or makes it harder to work. And we see that a lot on the behavioral health side of the world. There's a lot of different funding streams, as you heard Director Janine talk about. We have Mental Health Services Act funding. We get realignment funding, which is funding that comes from the state to provide mental health services. We get a number of federal grants. And it's hard hard to keep it all straight. And it's hard to know exactly what your community has as far as mental health services. The counties are responsible for the specialty mental health services, but we also do work in conjunction with other, let's say, education, NAMI, local community-based organizations to provide a wider range of services, as well. So for when I'm working in Sacramento, I try to remember what it's like to be in a community. And for behavioral health issues, we find a lot, if somebody is in crisis, it's really hard to find what you need when you're in crisis. It makes it hard to operate. And so making it as easy as possible to access these services is something that Mendocino County works on and that many other counties work on. We also see that for behavioral health issues, it's at the intersection of a lot of the policy issues that we work on in Sacramento and for each county. We mentioned healthcare overall. There's a big movement right now to integrate healthcare and behavioral healthcare, which makes sense. But we have a lot of complicated systems in California, and we've got to figure out exactly how to do that, or how best to do that. The criminal justice system, of course, and that's what the Stepping Up initiative is all about. Mendocino County, I believe, was the first county to join the Stepping Up initiative in California, and Elizabeth will speak more about that, what that means, and what that can mean for your community. And then the other area we see the intersection with often is homelessness. And I want to be sure, we've been talking with the governor about this, not all folks who are homeless have a mental illness. This governor tends to talk a little bit like that, and that's a good thing because he wants to commit resources and services for people who are homeless, which we are 100% behind. But we want to make sure that this governor understands that there's a wide range of people who are struggling with housing for a variety of reasons. And for those who do have a mental illness or potentially could have a mental illness, we want to be able to help them, of course. So as we work on these issues in Sacramento, I try to think of what's going on up here in Mendocino and the other areas of the state. I want to thank Supervisor Brown. She's been on the CSAC Board of Directors for many, many years. Has been a key component of helping us develop policy in Sacramento. And Elizabeth will talk to you about the Stepping Up initiative next. Thank you.
Have some slides I'm going to share with you. And I will add my thanks for this opportunity to come here. I actually also live in Sacramento, but you don't have to twist my arm very hard to come to Mendocino, so it was a delight and really fun to be here. I'm just going to give this a minute to load. My job tonight is to help explain to you all what the Stepping Up initiative is and what it's, what's involved in it. I know a little bit about what Mendocino has done as part of it, and it really will offer a chance for the county as you really move into the next phase of this work. So before I go any further, May is Mental Health Month, which you all may know, and that means that it is also the Stepping Up Month of Action. And so if any of you are so inclined on social media, you can definitely be a part of all of this. And there's our hashtag, Step Up for Mental Health, and we'd love there'll be things going on all month on Twitter and those other spaces celebrating this and talking about what counties are doing. So it would be great to have you share this, and we will certainly be calling out this work in Mendocino. This is, I think, the only county I know, and I don't think it was necessarily because it was Stepping Up Action Month. I think it's just because you all are really moving forward so heavily. But it's the only county I know of that's doing this kind of combination. We had an afternoon event where people were in the field, public events, in two parts of the county. So this is really exciting. So I work with the Council of State Governments Justice Center. I'll just tell you just a little bit about CSG, so you have a sense of this. It is a national organization. It is a nonprofit. and it actually represents all three branches of government. It works with executive, legislative, and judicial branches. It's been around for a number of years. The Justice Center is sort of the criminal justice arm. And so as you can imagine, does a lot of work to really try to help bridge and identify and help solve government problems. Some of you there are a number of great resources. There's a national reentry clearinghouse that CSG operates, as well as some of the justice reinvestment work, and we'll be talking tonight, obviously, about some of the mental health work. And I will actually get into a little bit more stepping up in a minute, and then our 6-question framework, which is really how the stepping up work is organized. And then we'll talk just a little bit about kind of next steps in Mendocino County and what that can look like. So how do we get here? It is one of the challenges that we have around this issue is that there actually is not great data in terms of really understanding how many people with mental illnesses are in jails. Despite the sense that around the country and definitely in this state, there's a perception that this is maybe even a growing problem. There's not a lot of great data, but based on the studies that have been done, it's been pretty consistently kind of somewhere between 15-20%. So the estimate is of the 11 million people who are going to jail, admitted into jail every year, about 2 million have serious mental illness. And one of the reasons, actually, that the Stepping Up initiative focuses on jails in particular, Carmel mentioned that I worked for the state prison system, because the admissions to jail are so much higher, affect so many more people. The state prison population is really a much more narrow percent of the population. So when we're talking about the impact that any changes in the county jail systems can have, we're talking about affecting many, many lives. So this is not a new issue. A lot of work has actually gone into this prior to the Stepping Up initiative, which was launched, as Supervisor Brown said a couple of years ago. Significant work's gone into it. Back in 1997, there was one mental health court in the country. Now we have hundreds, and as you heard here in Mendocino, we have one. We have them in probably most counties across the state. There's been a lot of work in trying to figure out how can we better address what Farah talked about, this intersection of the criminal justice system and the mental health system. And yet, really, all across California and really across the country, we find that jails really are still the de facto mental health system. There's kind of this question of how is it that this is such a problem, despite the fact that people have really been working on this for such a long time. And this slide is just to help sort of identify that while we don't have great data, the bottom line is that it's pretty clear that people living with mental illness are overrepresented in the jails. As Supervisor Brown said, by 2, 3, 4 times as many. And a significant portion of those individuals are living with co-occurring substance use disorders. And as you all know, and has been mentioned, and also then living with other complicating factors, whether it's homelessness, other chronic medical conditions, etc. This is a complex problem. So in addition to knowing that we have sort of a higher percentage of people in jails living with mental illness, we also see from the data that people with mental illness end up having longer stays in jail. This is an example where we see, this is Utah, one of the counties that we work with, and the lengths of stay about twice as long for people with mental illness. We also see, not just for people in the criminal justice system, but in general, really low utilization of evidence-based programs. So those programs that research has found is most effective. So if you remember back to the slide where we talked about, about 2/3 of the people with mental illness may have a co-occurring disorder, but you can see here, only 12% of this population is actually then getting integrated treatment to address both of those needs, right? Over a third actually weren't getting any treatment at all, and half were just getting mental health services. And this is a study done, this is looking at just the adults with both mental health and substance use co-occurring disorders. So we see that even when people are getting treatment services, they're not necessarily getting either the most effective programs or the treatment that they need. And so, unfortunately, perhaps, but maybe not, shouldn't be shocking, we also see higher recidivism rates. So this study found that we didn't necessarily see a difference in arrest rates, but what we do see is a higher rate of revocations for the individuals. This was a population on probation. And so these key factors that I just mentioned in terms of the number of people with a mental illness, how long they stay in jail, their access to treatment, and the recidivism rates are going to come back as issues as we talk about stepping up. But before I go into that, this is important as we try to really figure out strategies to address this. And I kind of struggled with this slide a little bit as someone who has spent a lot of time trying to advocate to make sure that we were getting more mental health services for people. But the more I understand this, the more I realize it is important that we grapple with this. So this was a study done out of by Jennifer Scheme and others from UC Berkeley. Don't remember them. I was actually just recently looking at it again, but it was a few thousand people, and they went back and they actually looked at the detailed information from the crime. And what this slide tells us is that it's important to remember that the incarceration, the crime for which someone is incarcerated, is not always directly the result of their mental illness. And so about, in this instance, 2/3 of the time, the mental illness itself was actually pretty independent from the crime that was committed. And less than 10% of the time do we actually see the mental illness itself sort of directly related to the crime that was committed. And so this becomes important because as we are developing more effective systems and really trying to target our resources, it's just important to remember that while, of course, accessing mental health services is critical, and that's why we're here, and that's what we're working on, there may also be other issues that need to be addressed. And so some of Dr. Scheme's other research has really found that there are different factors that research finds is related to criminogenic risk, is what we call it in the criminal justice field. And those can be things like housing or substance abuse, but they also can be things like thinking and attitudes and peers, etc. And when we put people who have those needs only into a mental health program and we don't address those other, what we call risk factors, we're not probably going to reduce their risk of recidivism. And so we maybe have these great mental health courts that we're putting people through, but if we're not addressing those other issues, we may not find the results that we were hoping for. And so this looks complicated, and I almost took it out, but I just wanted to leave it in because as we really think about kind of an effective system, we really like for systems to think about all three levels here. So what I just call the criminogenic risk, which, as I said, in the criminal justice research is really looking at kind of those factors that put someone at a risk of committing another crime. The substance use treatment needs and mental illness. And so what we need is to have validated, really good, effective assessments for each of these levels, and those exist. That's not hard to do. Well, two different things, right? So they exist, they're available. Implementing them, effectively can sometimes be difficult. So I shouldn't say it's not hard to do, but it is certainly possible. And your county's already doing some of this in different ways. But what you can see here is, let's imagine we had a system in which the people got assessed in all 3 of these areas, or even just screened in them. And so we would know right off the bat that if someone is at a lower criminogenic risk, we don't want to get them caught up in our criminal justice system. The research is really clear that if you get those people in with higher risk people, you will actually increase the chance that these people will continue to commit crimes, as opposed to, so you can make them worse, if you will. So let's keep them out of the criminal justice system, but they've had contact with law enforcement, whatever it is, so they have other needs too that we need to figure out. So let's say that we know, okay, well, if they have a mild or low substance use disorder, okay, let's not get them into substance use treatment, but maybe they do have a high mental health need, right? And so this is where you start to really figure out how to triage. And so in this category, what you can see is, these are the folks who really have low criminogenic risk. They shouldn't be sort of caught up in the criminal justice system, but they might have substance use needs, right? And then you can see how you can really end up kind of much more effectively targeting your resources. And we've done some studies in certain places where they, just kind of funnel everyone through a any, whatever court we're talking about, maybe a drug court or mental health court, and without really kind of doing this sort of assessment. And when you look at the effectiveness down at the end, it's like, people have kind of gotten funneled out for this reason or that reason, and they got into the wrong treatment program, right? They ended up in the substance use treatment program, but that wasn't really what they needed, et cetera. And then the effectiveness, you spend all this money in doing these programs, and the effectiveness at the end is not nearly what you were hoping for. So this is why I think it can be helpful sometimes to really think through how to really target your resources and prioritize the interventions the way they're most needed. And so really what that would end up doing is we talk about kind of moving away from a system where things are all just connected or cross-wired into a real actual system of care in which we are addressing all of these needs. And I think, and I kind of had one other slide that I tried to spare you, but now I'm going to tell you about it so much. So you just have to imagine it. But where we do these different assessments, and right now, if any of you work in this field, you know that, so if you're the one who does the substance use assessment, maybe you get that, but no one else gets it, right? Because we do not have good information sharing. That tends to be one of the big challenges in these areas where we're doing this cross-sector work. And so what if we really could do those assessments, actually have shared information agreements, be able to share that, and then be able to make decisions at the various levels that we need to. Wouldn't that be a much more effective system of care? So, in terms of sort of wrapping up this section, sort of how did we get here, right? It's like counties have stepped up, but they still continue to face a lot of challenges. Why is this so hard to fix? So that's where the Stepping Up initiative came in. So it was about 3 years ago when it started. And it was launched by a few organizations. I'll show you the slide in a minute of who was involved. But it was really about recognizing that we've been working with counties for decades. And people are doing good work, and they're doing hard work, and they care. There's not for a lack of caring on this issue. It's one of I mentioned I work on a number of reform issues, and the thing I really that's great about this issue is people really care. No one argues that this is not an issue. So why is it so hard? And so what they really came up with was the problem is we were still just kind of treating it with a pilot project here. And sometimes a pilot project might be a big one. It might be a behavioral court. It might be, right? But it was like this solution here, this solution there. And probation would do their thing, and the sheriff's department would do their thing. And before Medi-Cal expansion, behavioral health really had not much to do with the population coming out of jails. So it was, very isolated in the sense of accessing local services that way. And so everything was so fragmented, and there was not this systemic approach. And so that's what Stepping Up really seeks to do, is take this systemic approach and focus on 4 specific measures, which I'll talk about in a moment. And so really, the idea is it's stepping up to reduce the number of people with mental illnesses in jails. And so it's really about getting to that place and, like I said, measuring 4 specific things. These are the organizations, so the lead national organizations are the organization I work for, the CSG Justice Center, NACO, which is the National Association of Counties, FAIR works with the State Association of Counties, and then the American Psychiatric Association. You can see NAMI has been a key member of the steering committee, the Stepping Up steering committee from the beginning, and many other federal and state partners. Here in California, we've been working closely with CSAC, where FAIR works, as well as with the probation officers, the Sheriff's Association, and the Behavioral Health Directors Association, so the work we've done here. Many California counties have now, in fact, stepped up, and as you heard, Mendocino was the first one in our state. We still don't have every county. We sort of hope to do that, but we're working on it. Okay, so Stepping Up is organized around 6 key questions. And the idea is that if we can really focus on these questions, people can kind of work through this systemic approach. So the first is your leadership committed? And in Mendocino County, I will tell you that yes, your leadership is committed. But as you all can imagine, that still can mean many things, right? Just being committed doesn't necessarily mean that everyone has the right kind of time. Do we have the right, leadership may be committed, but do we have the right kind of staff? So there are many pieces to that, and we'll talk about it in a minute. Do you have timely screening and assessment? We'll go through what that can mean. Do you have baseline data? Which I mentioned before. So we're really talking about moving the dial on the number of people with mental illness, which means we need to know how many there are so that we know if we are making improvements or not. In order to do that, we really have to assess what's currently available and really identify the gaps. That then can help us prioritize the different policies and practices and changes to funding that need to happen. And then, of course, we need to track progress. So pretty simple on the face of it, but as you can imagine, a little more complicated once you put it into place. And then, as I mentioned, there are 4 specific measures. And these really end up being key because if you think about it, so number 1, reduce the number of people who have mental illness who are booked into jails. And so that, we talked about that's the main goal. But if you think about it, of course, it's important to have these other measures as well, because there are many ways in which we could do that, and we actually might end up putting people at higher risk, right? If we're not actually connecting them to treatment that they need, then we might see recidivism rates going up. And then, or if we're just keeping them in jail, we have fewer people in, but they're staying in a lot longer, that's not going to be, what we're aiming for either. So these 4 measures all together are what folks who have been working on this for decades really came up with, and like, this is what we need to do to tackle this. I will show you in a little bit, but there are not that many places that have actually been able to really do a great job about collecting all this data yet. It's not easy. Okay, so we'll just walk through these steps a little bit, some in a little more detail than others, but the first one is your leadership committed. So you know that you have the Board of Supervisors resolution, that happened a couple of years ago. You have a cross-representative planning team that includes the different, behavioral health folks as well as the sheriffs, et cetera. It'll be an ongoing effort for them always to make sure that all of the right players are at the table and coming with this commitment to this vision, et cetera. It's always really important on these projects, so you get all these high-level folks who are very engaged. Of course, you need to have the dedicated project coordinator, et cetera, and all of that becomes important with a commitment to accountability for results. Mendocino County's really kind of doing pretty strong in this number one. And I'm not going to be giving you like an assessment as we go through this. I don't know enough. But from my perspective, I think you're doing pretty fantastic there. In terms of timely screening and assessment. So remember with the behavioral health framework, we talked about really wanting to look at mental illness, but also at substance use disorders and recidivism, that risk of recidivism. And so ideally, you want to get to a place where you're able to do timely screenings and assessments of these. That you are using validated screening and assessment tools electronically collecting that data. So you actually already do universal screening in the jail, which is great. Lots of folks do not. I think that it is definitely worth looking at the tool. I think it's been in use for a long time, as we move into this era in criminal justice and in health, where we're using more and more assessments, we talk more about needing a tool to be validated. And I think people are still really figuring out kind of what does that mean, other than kind of nodding to, yes, we know it needs to be validated. But you want to make sure if you're using this assessment or the screening tool to help flag who might have a mental illness, then you want to do a sample, a research study to go back and look, well, did it in fact flag the right people? And so there are people. It's not as daunting as it can sometimes seem to do that. It's really important. And there are some other assessments that are available that are actually free and part of the public space, et cetera, that can be used. So in all of these, there are definitely ways to do it. And it just ends up being this critical piece that sometimes can kind of just sound sort of bureaucratic, but it's an important piece of it. And this is just kind of the difference between the screen and the assessment. So the screen should be given to everyone at booking, and it can be very simple. It's we don't recommend specific tools because there are others available, but they can be done. They actually don't even have to be done by a health professional. There are many that have been validated that can be short, and they'll just flag. This person should be given a full clinical assessment, and then that would be what would inform a diagnosis and a treatment plan, et cetera. And so that's really the difference. And so that universal screening is important. Lots of jails are really kind of just doing like maybe a suicide risk. I think all jails in California are doing suicide risk. And so this is more than that. But again, we're not talking about the full clinical assessment for everyone at booking, but we really should be screening. Otherwise, too many people are going to fall through the cracks. And we'll have no idea what our prevalence rates actually are, right? We won't actually know if our problem's getting better or worse. This was that slide I described to you. So this was, right, so if we're talking about the different kinds of screenings and assessments that we could do, and right now we have, so a mental health screen, which I said, sometimes the suicide risk, and maybe only the jail intake staff are looking at that. Then you might have the LSI is an assessment tool that a number of criminal justice probation departments and others use around risk assessment, but maybe they only look at that. Sometimes you'll have assessments and tools that people feel like no one actually looks at, right? And they're all going different places. But the idea is, if we're using these assessments, let's use them, let's share information, and then let's use them to actually inform where it's safe to house someone in a jail, whether or not they're safe for pretrial release, what kind of diversion programs they might be eligible for, how can we actually connect them to care at discharge, what kind of community supervision, if any supervision that they need. So really using that all to inform our actual decision making. So question number 3, do you have baseline data? And so these are the four measures that we talked about before. So people who are booked into jail with serious mental illness, their average length of stay, the percentage of people who are actually then connected to care, and the overall recidivism rate. So those are the measures. Why do we care so much about them? Well, we already talked about the fact that if you're not looking at all 4, then you might actually see an improvement in 1, and it turns out others are getting worse, and if you weren't tracking that, you wouldn't know that, and you might actually be having the opposite impact than you were really intending to have. So in order to do this, as we talk about one of the things that needs to happen, and this is where we really get into the bureaucracy of it, your folks have already done this, but is really haggle over what are our shared definition. Because unfortunately, serious mental illness is not something that there is just one definition for, depending on whether or not you're talking about the federal funding streams or to different places we use different definitions. And so one of the things that we actually did on a statewide level was pull a working group together and kind of try to come up with some recommendations around shared definition. And your folks here in Mendocino have done that. You want to ultimately get to a place where you can electronically collect this data and share it. And I was hearing in one of the afternoon sessions that there is actually, I think, some efforts underway that may make that more possible. I think right now to get the data that Supervisor Brown read, I think they manually had to go through some files and do the counting, et cetera, to figure out how many people we're talking about. So that can work for a while, and but if you're really talking about trying to get to these systemic reforms that we want to do, that's gonna definitely slow you down. And then so we want to have baseline data so that we know if we're seeing improvements, and then that requires, of course, routine reports and regularly looking at it. I mentioned to you that there are really, now there may be more counties than this, and when Mendocino gets there, I want to add a gold star. But so there are 9 counties across the country that have said they actually kind of committed ahead of time, we want to get to a place where we've got this easily accessible and accurate data meeting sort of the criteria that the steering committee had set up. And so Calaveras County in California is one of them, so those small rural counties. This does not have to be a big county solution. And they really have done a great job at working on that. Okay, so the other reason why it ends up being so important to collect baseline and to collect the data in these 4 measures is because it's going to help you then figure out where are our challenges. This is such a complex problem, and people have lots of ideas about what could potentially help. And so these are just a few examples, but, let's say that what you find is that, we're seeing improvements in a couple of the measures, but our length of stay is just still getting longer and longer, Well, okay, maybe that's, you really need to make sure that everyone is actually getting screened and assessed. Maybe that's, maybe there are people on the low risk side who could be diverted. It helps you kind of then target, narrow what you're specifically looking at to address. Question number 4. We actually started, or did a little bit of this in the longer session this afternoon. So this is, I'll tell you more about that in a few minutes, but so have you conducted a comprehensive process analysis and service inventory? So I don't know, that's kind of like a fancy way of sort of saying your system mapping. Have you really figured out what you have locally and where your gaps are? There are many different ways of doing this. I'll show you a couple of examples. And that then helps you to identify where are the gaps and challenges. And they may be in processes, they may be in capacity. When we were doing an exercise earlier this afternoon, there were a number of areas where people said, came up that we have this great service. The problem is it just doesn't reach nearly enough people, right? So, and you solve these problems differently, right? In some instances, the problem may be that we're not connecting people from one place to another. In another instance, it may just be that we need to expand capacity. Do we, population projections, so one kind of being able to sort of estimate here's what's needed, and then the other thing that came up was how important it is to have culturally responsive services and programs. So you may have capacity, but it may not be reaching or effective with all of the different populations that have a need to be met. So all of that becomes really critical as you're doing this this inventory. And then, as I mentioned before, it's critical about whether or not the services that you're providing and programs are actually evidence-based. So you really want to kind of go through that. And that research, that field is growing daily. So this is an example of one of these maps. This is LA County. Not the most simple of maps. There are many that are much simpler. However, I think if you were really to map out your system in Mendocino County, it's probably not much less complicated than that when you take through all the steps and the possibilities that are available. So it doesn't matter that if you can see this, that's amazing. But I can't see it, and I'm standing way closer. But this is based on something that's called a sequential intercept map, which is something that a number of counties have been using. It's not the process it's not the only way of doing mapping, but it basically looks at what they call these different intercepts, where people come in contact with the criminal justice system, and you really kind of map through the process and what's available, and it ends up being a good way to identify where they call some of the flags and opportunities for connection and that might be being missed. This was an example of something that Santa Cruz County did in trying to identify their system. This was Yolo County. This is kind of similar. And again, I'm just kind of showing you there are many different ways to do it, but here you have it, and they sort of said, okay, here's the incident. The person, did they go right to home, or did they get booked into jail? If they went to jail, then this is, I think, ER. Then this is, right, so some people might have gone directly to ER and then to jail, right? And so it's actually a really fun process to go through to do this kind of mapping. And you have to do it with people from lots of different fields, because I was able to do some of this in San Joaquin County not that long ago, and it was like you're sitting around the table, and one section, one person's doing all the talking, and then you get to kind of the next part of the map, and suddenly it's the different section knows, the different person knows how it works. It really calls to light all the silos we have and how much we don't know about each other's systems in many instances, and how things work differently than how people actually thought they worked. So it can be important. And so then you get to, so have you prioritized policy, practice, and funding? You all have done some amazing things about identifying some needs and either using your mental health services dollars, the Prop 63 funding, MHSA, or now with Measure B, that is going to create a resource. I mean, there's, again, no shortage of caring about the issue. And so, these kinds of steps can really help you then in prioritizing what you need to focus on. And be able to reserve, kind of your most restricted funding and your county general funds for those things that are really high priority and for which there are not other funding sources. This is an example of how that can work. So this is a county in California where their number of people in their jail with mental illness was about 500 a day. And so this was their baseline measures of admissions. They don't have ongoing data collection, but they did like proxies to be able to get some baseline measures, which is another thing that counties can do, just so that sort of knew where they were starting from. And so they had their admissions rate, their length of stay, the percent that they had figured out were getting connected to treatment and recidivism. And so for the first year of this plan, they set a very specific goal that they wanted to reduce admissions by 10%. And so what they did with this is just one of the steps, but they kind of said, okay, well, if that's our goal, if that's where we're going to focus our efforts this year, then, where are some of the gaps? And so one of the things that they realized was they had CIT training, trained officers. CIT is crisis intervention training, where you train law enforcement officers on sort of more appropriately showing up in an incident in which someone has a mental illness. But those officers were not the ones that were available 24/7. And so similarly, we started just doing a little bit of this here today. Again, as I mentioned, people might identify an asset, but that also, the strength that you have locally, but there may still be a gap tied to that. So this was what they had found, and so then they kind of came up with their measures, and here's what we want to do to address that, here's how we're going to fund it, and here's how we're going to track that. So just an example of kind of how you can go through this really deliberate process of addressing these issues. And then, of course, for a data-driven project, you need to then be able to really track the progress, figuring out what the timeline is going to be for which you're tracking those 4 measures, have a process for doing that, and ongoing evaluation, because things may be going in the direction you thought, or they might not be. Okay, so really to just talk a little bit about next steps in Mendocino. This is a process that we just started this afternoon, and if you all signed up at the sign-in today, we're actually going to be gathering all of the notes from that. You can see some of them still around the room, and sending them out, and then collecting more information to build off of it. So this was just really the very preliminary kind of step 1 around this. So what we did was we looked at these stages: prevention, intervention, then when an incident occurs, jail booking and services, what kinds of diversion and adjudication options are available, and what's available in terms of post-release connection to treatment. And so we went through, so you see up here, in each of these steps, we looked at assets and gaps, and then we went through it for each of these phases. And here in prevention and intervention, this is really like assuming this would be, we wouldn't even have to involve law enforcement, right? What would we do to be able to address this prior to any law enforcement contact? So we looked at, what does that mean for schools? What services do we need to have in schools? Housing first models, supported employment, trauma-informed care, other integrated approaches. What would we need here? So, what are the assets that already exist, and where are real gaps? And then in terms of when the incident actually occurs, so who's contacted, what kinds of resources are available. So this is where some of the things that came up were 911 dispatch training, and a gap between, so who do you call when it's not really a 911 call, but the crisis line is only going to take it if they would be going to the emergency room, right? So that kind of thing, or also maybe needing training specifically for 911 to really help understand this is a mental health related call, so that who can they dispatch, and what options are available, how do you make sure that it's a CIT trained officer that then shows up, etc. So this is kind of some of the pieces that can come in place there. In terms of a jail booking, we talked about having really universal screening using a validated tool, then having a whole assessment for people who screen positive, the information then shared with the people who can effectively use it, and making sure that there are actually access to evidence-based services for those who do need to stay in jail. Then, for those who do not, there are the appropriate diversion opportunities, and this really, there are many different forms of diversion. One of the gaps that came up was being able to do some pre-booking screens, so that if someone is eligible for diversion, can we figure that out before they even get booked into jail? So that came up as a need here today. There's actually some recent legislation that is potentially authorizing some additional mental health diversion. There's some folks starting to look at that. And then in terms of post-release connection to treatment, so what happens after someone's released? I think you heard, so Mendocino County has just recently hired a discharge planner. He ended up being one of the assets listed on kind of everybody's chart. It's a great resource. But we were also talking about the problem of really continuing to engage people after they're released. And so we were thinking, is there an unmet need that peer support could help to address? Definitely, there's some services here that certainly could be expanded a lot more, and so that's certainly an area to look at. And then also thinking about the intersection with these other areas that we talked about in terms of substance use disorder, and or if there are other areas that putting people at risk of recidivism. So those are the kinds of things we looked at and just began to scratch the surface. Lots more to come and exciting work, and I know that there'll be a chance later for question and feedback, and if people have some ideas you want to raise, that would be great. I just want to let you know about a few resources that are available. There's actually a ton of resources available on the Step Up Together website, and more than you'll want to know. There are webinars for each one of the steps that we talked about. There are toolkits on the measures. Lots of different things. I talked about the model, the definition. If you really want to get crazy with that, you can. There's a handbook for project coordinators that really kind of walks through different exercises. Counties can do their own self-assessment. And you can sign up as an individual and sort of say, I support it, and maybe have access to all these resources, webinars, et cetera, things about screening and assessment, things about funding opportunities and ways to really do the planning and then identify the correct funding. So lots of resources on that website. As I mentioned, May is the Stepping Up Month of Action. So we would love for you to go on and participate and let us know about anything that is going on in Mendocino County. This is kind of the schedule of the month in terms of what we're hoping folks will do and identifying different things in different weeks. But mostly we just want to know what's going on locally. So thank you all very, very much. It's really a pleasure to be here.
Thank you, Elizabeth. I'm really excited about the next steps for Mendocino County, and to have NAMI in Mendocino County share a little bit this evening to take this really important data and information that Elizabeth shared with us tonight and really make it real with some real life stories here in Mendocino County. So it's my pleasure to introduce you to Dawn Muschetti, our local president of NAMI Mendocino County, and she's going to introduce some of her colleagues and friends with NAMI Mendocino.
Thank you. So I'm going to take 2 minutes and talk about NAMI first. I am Dawn Muschetti. Ooh, I said I hate that. I'm Dawn Muschetti, chair of NAMI Mendocino County. And I'd like to thank first and foremost behavioral health, mental health, Janine Miller, and especially Tammy Moss Chandler. Thanks to them, you need to understand, thanks to them, we have an office. We would not have it without them, so thank you very much. It is at 564 South Doris Street, Suite E. We have a comprehensive mental health library, and anyone is welcome to come in and check out our books, our media, everything. We offer family-to-family classes, which are for family members who have someone who has a severe mental illness. It doesn't have to be severe, it could be non-diagnosed, it doesn't matter. We have family support group. We have peer-to-peer, which is for peers, people who have mental illness. And we have connections, which is a support group for peers. So that's my quick deal on NAMI. If you have any questions, need anything, we have brochures in the back. My number's in there, you can call me anytime. And we have coffee now, which we didn't have earlier. So, my story. My story is, my boy is my godson. His mother suffered from schizophrenia, and in the mid-90s, she was in and out of jail every other day. Unfortunately, she committed suicide in 1997. He grew up, and sometime between December 26th and December 30th of 2008, he had his first psychotic break. His grandmother, who has been dealing with mental illness in her family forever, knew exactly what was wrong with him. Back then, she tried to get help, there wasn't any forthcoming. September 27th, 2009, and it's funny how you remember dates. You just remember. He had his first confrontation with law enforcement, and he was arrested for failure to submit. And he served 3 days in juvenile hall. In October of the same year, he was walking down the middle of the street and an officer went up behind him and it scared him and he ran off. It was a bad experience and he was arrested again for resisting arrest, jaywalking, the whole 9 yards. And he was in juvenile hall for 14 days at that time. In February of 2010, he was arrested for trespassing. And he went to juvenile hall for 5 days. In April of 2010, he was arrested for a parole violation and he spent 35 days in juvenile hall. Finally, he received help and he was 5150 and he lucked out completely and totally. It's a luck out story. He ended up with a psychiatrist down in Vallejo who didn't have an ego, and after 25 days there, they were going to have to let him go pretty soon. And so she called in 2 other psychiatrists and they got him on the right cocktail. So he's been med compliant ever since. He came home on June 13th of 2010. From June 13th to today, he has not had 1 instance with law enforcement. Nothing. 0. So in 7 months, when he was not doing well and ill, 59 days he spent in juvenile hall. 2 months out of 7. Since then, since he's had help, he has a support system. His grandmother, excellent. He has a psychiatrist who's excellent. 9 years, nothing. It's very important that we make sure that they have the support and they get help when they need it. And that's my story.
Hi, my name is Pam Gordy. I'm chair of the Behavioral Health Advisory Board as well as being on the NAMI board. And I don't want to go into my whole story today. I just want to talk about my son's experience with the jail. But I have a disclaimer. This happened in 2012. Things have changed somewhat since then. And I also want to mention that my son had private insurance. And then and now, there's very few services for private insurance. Most of it is for people who are on medical. When my son was a young adult, he had had some setbacks in life, and he was seeing a counselor in Santa Rosa. His behavior had become more and more erratic, and one day the counselor asked me if he had had contact with law enforcement. And I was really surprised. What does law enforcement have to do with this? Well, silly me, little did I know. My son was prescribed a variety of medications during this time, but eventually he stopped taking them. So just an aside, the psych meds, if you don't know, can be very tricky. An individual who needs to take them must weigh the cost and benefit ratio of the med compliance if the side effects are really severe. So anyway, he stopped taking his meds and became increasingly violent, and we had to call 911. Oh, look, we get to have contact with law enforcement. Surprise. I must say we had a good experience with the sheriff's deputies who came out. They talked to us first, and then they talked to him when his time was not out of control, and said they would take him to see a nice lady. What they meant was they were going to put him on a 51 hold for psychiatric assessment. In summary, he was hospitalized 3 times, and we had to kick him off our property because of his behavior and his refusal to be treated for his illness. He became homeless, but not for long, because he finally lay down in front of Safeway and wouldn't move. So he was booked into jail for some misdemeanor charge. The public defender took his case herself. Not too much later, he was released from jail, and right away I got a call from her. She said he'd been released, he got his hands on some alcohol, and had been rearrested in St. Mary's School. So this was very puzzling to me because I knew he didn't have any money, and there were no liquor stores near St. Mary's School. So later, much later, I asked him about this, and he told me that behavioral health had picked him up in the jail, and they'd taken him to their office on Dorr Street, and then they told him he could leave. Well, he didn't have any place to go. I told him they thought he was drunk, and he asked if there was a breathalyzer test. Well, silly me, I hadn't thought to ask that at that time. He said he was psychotic, and he didn't know what to do. Remember, they just told him to leave, and there was no plan of where he would go, what he would do. So he went into the office at St. Mary's to ask for help. So he ended up in jail, where he stayed for 6 months. He still refused to take his meds, even though I spoke to the jail staff frequently and brought his meds to them for him. He was reportedly provoking other prisoners, so he was placed in solitary confinement to protect him, where he quickly decompensated. He lost a lot of weight because he wouldn't eat. He was hallucinating that there were worms in the food. And he generally refused to see me when I went to visit him frequently because he didn't want to leave his cell. When he appeared in court, chained and in orange, he was completely unkempt and laughed hysterically. The judge ordered meds, but they weren't given. The judge ordered competency, but there were no beds available in the state. Finally, he was given court-ordered medication and had immediate positive response. All charges were dropped after 6 months of being there, and the judge asked him what he wanted to do. He asked for a hotel room, but behavioral health took him to a homeless shelter in Fort Bragg, even though he was concerned at the time. He became med compliant, thank God. And with help, I had to call behavioral health in Fort Bragg and come on board. He began a road to recovery. As a result of our experience, I've become a rabid advocate of mental health services, which are still pretty useful. I'm very hopeful with the goals of the Stepping Up Initiative for Jail Diversion. The process calls for collaboration across a broad array of public systems which currently act independently. Currently, each system has its own set of rules, written and unwritten, and its own data management system, but each is separate from the other, and there's little, if any, communication between them. This severely affects people's lives. When one is suffering from mental illness, they are often traveling a quagmire of obstacles that ends in the prison system. So by default, with no other place to go, jails and prisons have become the new mental institutions. The only metaphor that I can think of is an automobile. So if your car's not working, you take it to the mechanic shop, and the mechanics fix the part that has the problem. Transmission, the brakes. This is like if someone has a certain ailment, like a broken leg or a heart attack or cancer, one goes to the doctor or the ER or the hospital and sees a specialist who addresses the problem, and everybody gathers around, friends and family offer their thoughts and prayers and support. But in contrast with mental illness, it's like taking that same car into a shop where it's completely dismantled. The brakes may be fixed, but the tires are sitting in the corner. The chassis is lying by itself in the middle of the floor, but the body's somewhere else. So there is no way that car is going to move out of the shop on its own volition, even if all the pieces are in working order separately. This is what it's like going to the ER for help with mental illness. Even though the hospital may claim its vision is to improve physical, spiritual, and mental health, and make care more accessible and affordable, they really don't want to see mental health patients. They can either send them to the psychiatric hospital, they can send them to the street or the jail, or home with them. And family and friends shy away because the whole thing is so embarrassing. To me, this is what the mental health system looks like. Surely, there is a bad way. Our society as a whole has become very compartmentalized, but we need to find a way to come together for the betterment of mankind. Nowhere is this more apparent than in treating mental illness. If people need help, they should be able to move seamlessly from one public agency to another in a coherent manner. All of these agencies are there to serve the public and society. They must be able to get medical help like any other disease. People suffering from mental illness must be diverted from the dead end of our default mental institutions, prisons, and given a chance at life.
So now you're going to hear from our peers, and you're going to hear the true story of what it's like. John.
So I am wrong.
I am so proud of these
That's
guys.
age before beauty.
Yeah, I am so proud of these guys, it's not even funny. It's hard enough as a family member to come out, but for these guys,
Yay. All right, I'm John. Hi, everybody. Hi, John. As I was listening, I was thinking about, how so often I go, I wish they had that when I was back, in those days when I was in a lot of trouble. But I see that, I hear and see a lot of people coming together to try to always make things better. They didn't have all this stuff, any of this stuff back then. And as I told the earlier people that we talked before, that my disclaimer is that I'm going to tell you something, and you need to know it happened a long time ago, so you don't have to worry about me today. I'm not doing what I used to do. Okay, it was a long time ago. So I've been through the juvenile hall many times. I spent most of my youth there. Then jail, prison, CRC, Delancey Street. A lot of anything the state of California at that time had to offer. That's what the judge said. Well, we've tried everything we have to offer. We don't know what to do with you. And I didn't know what am I going to tell them? Oh, well, here, how about try this? And I'm telling you this because when I was growing up as a child, I came from a very abusive, very, very volatile, violent, hit John over the head with pipe wrenches, stuff like that, hold me in sleeping bags for hours, all kinds of stuff. And I thought that was what everybody did. I thought everybody's family was kind of mean like that. I don't know why I would think any different. Nobody told me any different. So in the 4th grade, I got kicked out of school for socking my teacher in the face because something happened. And I was kicked out of every school I've ever been in since. And I would think, well, man, there is really something wrong. I don't know. And what happened was it became attributed to drug addiction. Makes sense. The guy's an addict, and he's doing all these things, right? But when I was a little, 12, I think I was 12, I don't know how old I was in 4th grade, but I wasn't using drugs then. There was something else going on underneath, but it never got noticed. It was never ever, and to this day actually, has never been diagnosed or looked at or any of that. I have never, the truth is, I had a diagnosis one time in prison, and it was like 20 minutes of blotter testing. They said I was homicidal or something. I don't know. I don't even think it was a real diagnosis. And that's the only time I've ever had any kind of diagnosis whatsoever, except that, John, you are an addict. You're a drug addict, you know? Well, looking back, I remember, you know, as a child, somebody was talking earlier about a youngster, and I identified with that youngster, and I thought about how I felt. And I always felt like I didn't fit, there was something wrong, and no, I didn't know even how to say, hey, something's wrong. I didn't even, nobody picked up on it, I guess. You know, it just kind of went undetected. So, I look back and I think, wow, it would have been kind of cool if I would have, if maybe my underlying issue that had been there the whole time, since I've been held in sleeping bags for hours, maybe that's has something to do with this. But in another program that I have been involved in for quite many years tells you to not worry about what. Doesn't matter, you got it. You're an addict. But when I'm looking and have been exposed in such a beautiful way lately for the last 3 years, I see that it's important to know why, because for me, it means that there was always the underlying issue, always there, but never identified. And so all of the things that went down behind my addiction, coupled with PTSD, is what I believe it is. I could be wrong. I'm not a clinician or one of those guys, so I don't know what I got. But I feel like I got PTSD because I get freaky sometimes. I go, wow, A lot of people. I went shopping one time. They told me I had to go grocery shop when I first got clean, and they gave me food stamps and told me to go to Safeway. And I had 4 panic attacks before I finally got out of there with all the food. Something was up with me, and it wasn't. I wish that drugs was the problem because I'd be cured. I don't use it. I'm good with that. That has never been the problem. It's just been a symptom. The underlying issue for me is the core. That's where the core is. Is where it's home. Where I live is my reaction, my heightened level of freak out when something happens. That, like, if a car goes off right now, like that, I immediately go, and I can't help it. I wish I could. I tried. I used a lot of drugs. It didn't work. It got me in a lot of places. And so, one thing I'm really grateful for is that I'm becoming very aware of a whole different world, not different, but a whole connected world to my disease of addiction, and that is my mental health. And I pursued that, working through the program and working through the steps and doing that. I pursued, trying to be able to come into a room of people and sit down and not have sweaty palms. I try to force myself to do that first. It doesn't work. I try to deal with, at that level, with the things that I could deal with, but it never got to the core where I live. I don't know what my solution is. Because I still got it. I still got it. And so, that sucks to live with. But I got to tell you that every day that I didn't have, that I couldn't get a hold of, whatever it was that was going to make that go away, that was going to make it stop, I suffered if I didn't have some way to make it stop. So, I've always been like this guy who goes, oh no, if you're an addict, you don't use any, you do not take any medication no matter what, blah, 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 right? Black and white. Well, that's not true for me not today. And I don't know whether I need meds, you know. I'm a little leery of finding out. It's kind of like I'm a little leery of going to the doctor to find out if I have cancer. You know what I mean? It's like, just don't tell me, then, you know, it'll go away. That's the only solution that my mind comes up with, but I see results in people. So that gives me hope. Anyway, I don't know what else to say. I mean, you know, really.
You did a great job.
Yeah.
You did well.
Yes.
Now we're gonna have Crystal.
Hi, I'm Crystal. I'm a rapid cycling bipolar. So some of you may be familiar with the term bipolar. There's some commercials about it now. You know, it's like, oh, they're either very up there or they're very down there. That's true for a lot of us. Me, I go like this daily. I go like this. Your very best day, like the most excited day you have ever had in your entire life. I get those a lot. Your worst day, your saddest day, like the day you wish you were dead. I get those a lot. The angriest moment you've ever had, right? That's what happens to me when I get angry. When I get irritated, it's your level of anger, but I'm just irritated. So, I'm going to tell you a story, true story, full of facts. This is my story. I have never felt normal. Not ever. My earliest memory is about 5. I woke up one day and I couldn't remember anything prior to. I couldn't remember going to bed, having dinner, going to school the day before. I couldn't remember anything. I remember that day really clearly. And from that point forward, I never felt normal. I didn't fit in anywhere. I was very emotional. I was very erratic. I come from a severely abusive household. My trauma started at a very early age. So I always attributed not feeling normal to that, right? There's always a reason. Oh, well, it's this, right? Oh, it's that. And because of that trauma, because of not feeling normal, I had a lot of behaviors that came from that. And I would act very erratically, and people got used to this, and it was just Crystal. Oh, that's just Crystal. I do these super crazy, insane things, and people would just think, oh, well, that's Crystal, fine, that's what she does, you know. I have an aunt who many years, well, a few years ago, told me that herself and several of the people in my life at that time did not believe I would make it past 21 because of my behaviors. So, we're going to fast forward. Crazy teenagehood, you can imagine, and super rebel right here. I was 18, and someone introduced me to methamphetamine. Okay. I fell in love immediately because I felt normal. It was like the first breath of air. I felt straight. I could think clearly. I behaved normally. I could contain my completely insane levels of emotion. For a long time, people didn't know that I used. I was so straight. And that was awesome, right? But I became addicted. So I'm also a drug addict. That's never going to change, right? I don't use, but I'm still a drug addict. but I'm also bipolar. So I used methamphetamine consistently for a handful of years. And I had children, and I had a child who saved my life. But I struggled with my addiction for years. I mean, years. This is like, I'm 38 now, okay? My daughter's 17, she'll be 18 very soon. This is really difficult to talk about. I'm shaking like crazy. I don't know what the difference is between earlier this afternoon and right now, but for some reason, this is a lot harder to tell. So I struggle with my disease, which means that I relapsed. You know, I'd get 60 days and I'd relapse, 90 days and I'd relapse. Couldn't get a year. I absolutely could not get a year. And I tried for 15. Okay, so we're gonna fast forward through that. My child's about 9 years old. And part of my mental disorder is that I have suicidal ideations, right? Which means that sometimes what happens is my mind tells me that the only solution there is death. That's it, right? That the only end to my pain is that. I tried to kill myself 3 times before I was 13. I was very serious. That's not normal. In case you didn't know, that's not normal. So she was about 9, and I had life situations that I couldn't cope with, and I went back to what I knew. My mom had a 9mm gun that I stole from her safe, and I took it down to the river, and I spent about 6 hours with it pointed at my head and in my mouth and so on and so forth, trying to find a way to pull the trigger, because I knew that I was a problem and that it was never going to end. Like, I was never going to not use, I was never going to not cause harm, I was never not going to feel the way that I felt. But I had children, so I couldn't do that. So I did the next best thing, right? Brilliant. Okay, I'm gonna go get loaded. That's what I'm gonna do. I know how to fix this. And it had been a while, and I went and I got loaded. And I got really loaded. I got too loaded. I mean, being loaded is too loaded, but this was insane. And I burglarized the house. It was my fiance's godfather's house, so I've been there. I went in and I rifled through their personal belongings, and I took insignificant objects. I stayed there for hours on end. I have no idea why I did this. I know that I was very angry. So I inadvertently told on myself, right? Because I'm good at that. I'm really good at telling myself. I don't know why that is. It's not good when you're a drug addict. It's not the best quality to have. But I told on myself, and I got arrested. And they gave me 6 months, and I did half. Mind you, I was still unmedicated this whole time. And they put me in jail, and then I wasn't using anymore. I had nothing. I had no buffer between me and my disorder. And I was in jail. So I had to really be careful about how I acted. I had more than half of the COs on the floor threat to put me into isolation because I could not stop crying. I was targeted by the entire dorm, except for 2 other inmates who were there doing like 2-3 years. They were older, they'd been through it, so they were more seasoned. I had a target on my face when I came in. All I had was women in prison from the 80s movies. Like, I'd seen 2 of them, so I had this whole idea of what jail was going to be like and how horrific it was going to be and how, you know, Big Bertha and all that. Like, I had this idea in my mind. So I was terrified when I went into jail. So I did my time, I came out. I got violated. I didn't get violated. I did something that allowed me to get violated. I didn't show up to court So they issued a bench warrant, and I was at Motel 6, and I was there with my daughter. And I hadn't gotten loaded. I wasn't loaded. Hadn't been loaded in a few days. I was about 2 weeks away from a rehab. This thing was supposed to save my life, right? And the cops knocked on the door, and they came in and they searched everything. They tore all my stuff apart. And they found a tie, which if you don't know, that's what intravenous drug users use. And they told me, he told me that I was loaded. And I told him I wasn't. And he told me that if I didn't admit to being high, he was going to put my daughter in a separate patrol car, and I was not going to see her again. So what'd I do? I'm high, right? I'm hella high. I'm so high. Just put her in the car with me. So they put her in the car with me, and she rode in the back of the squad car to the police station. They let her stay with me while I was cuffed to the bench. And the whole time, the arresting officer was giving me shit for being a drug addict, for being in that situation at all. And maybe he was right. I have a really different opinion of that. On paper, I look really bad, you guys. If you were to just look, because they took her, she became a ward of the state. And I have a file, and it's this thick. And this is from years of court dates of going in. And the front of that file, it's about that thick, is every egregious thing that I ever did. And every horrible opinion of me as a parent. What you will not find in there is a diagnosis. What you will not find in there is treatment. What you will not find in there is all the steps that I have taken. She's still technically a ward of the state because of my mental disease and a lack of treatment and a lack of somebody catching it. He said it, nobody caught it. Nobody caught it. My experience of jail was horrible. It was bad enough to keep me out. Right? It was bad enough to keep me out. I didn't get medicated for a long time after that. It didn't. I struggled with my drug addiction and my trauma, and I would address one or the other, and I could not address them together because I did not understand that they went hand in hand. And nobody around me could tell me that. So, fast forward to almost 3 years ago, I had a break. And everything was too much. Everything became too much. And I was hospitalized. Wow, this is so much harder than it was. Jesus. Okay, so I was hospitalized. As a very matter of fact, this is what happened, okay? Good. So I got hospitalized. They put me on some medication, didn't work. They put me on some different medication, didn't work. They put me on another medication that had an adverse reaction and I ended up delusional. So they put me on a different medication. So now, because I'm a rapid cycling bipolar, there's a huge category of medication I can't take. I can't take it. Because it sends me into a delusional state. It exacerbates everything that's wrong. So, throughout this whole process, I was always aware that something was wrong, right? And throughout this whole process, it's been difficult to navigate. We're very stigmatized as mental cases, for head cases, right? People are afraid of us. We don't act right. We don't fit in. People look at us funny. My children have looked at me and they were scared of me because I was symptomatic. There are some times when I cannot be around my children because I'm symptomatic. I can't be around your kids either. I can't. But today, I know what's wrong. All it is, you guys, literally, is a piece of my brain. It's just a piece of my brain that isn't the same as yours. Right? That's it. It's the only difference. What I do today is good. I do my best to take care of my mental health. I do my best to keep my support system informed. I have been incredibly lucky. The place that I went for therapeutic services saved my life. I've been hospitalized 3 times in the last 2 years. I think it was last month was the last time I was hospitalized. See, so even with medication, even with support of your friends and your loved ones, it's still there. And it can still flare up like arthritis. Right? You wake up in the morning, there it is. You didn't want to wake up this way. You did, but you did. Today, I'm medicated, and I haven't had a single urge to use. I don't have a desire to get moving, which for me is the biggest part. Because I've spent so long identifying as a drug addict that I forgot who I was. So in a way, this mental health diagnosis has been a miracle, right? It's a miracle for me because it doesn't mean I'm not just a drug addict, right? I'm not just the scourge of our society, right? I do good shit, people. I do really good shit. You have no idea. Do you see how well put together I am? Do you see how normal I look? This is some JQ citizen stuff right here, right? Yeah, but I was in green and orange, and I was in a paper suit at the hospital a month and a half ago. I went there willingly, just so you know. I didn't resist arrest or anything. I knew something was wrong, and I took the steps I needed to take to get where I needed to be, because I could do that today. But I am just me, right? And this is just my experience. There are so many of us that don't have a positive in their story. I have been able to flip this with the help of a lot of people. So my message to you is that we are people first, right? And I have the same organs that you do. My skin looks a little bit different. My brain's a little off. But other than that, I am literally just like you. I mean, I'm chronically unique, but aside from that piece, I am just like you. We are the same, so thank you so much.
Thank you, Crystal. Thank you, John. Thank you, Nami of Mendocino County. Crystal, you did forget to say one thing. You are a good person.
Oh yeah, I am a good person. Yeah.
And I know we don't have much time left, but if you have burning questions that you want to ask in front of the whole group, I'm going to give you a few minutes to ask that. And Elizabeth's going to close us with a couple of words. And Carmel, do you want to say anything this evening? So Elizabeth, if you join me up here. And if anyone has a question for Yami, they're ready for a question from the public. Anybody has a question for Elizabeth or Farah about the presentations they did tonight, you can ask right now in front of the whole group, and we'll certainly stay after a few minutes. But John has a question for Elizabeth.
I heard you talking about the jail part and the triage, and I thought, wow, that's so awesome, right? But what I was thinking when you were saying it was, when you have a person come in and they're triaged and and you decide they don't fit the criteria to be in jail, where will they go?
Good question, John. What, revert to what, right? Yeah, and so, I mean, I think that, in fact, the legislation that was recently passed sort of says, people will be diverted as long as there is a viable treatment plan. And so, that's really what hopefully some of this planning can help identify. What would the most important gaps be, and then we continue to get additional housing. I mean, right, that's the problem. And that's actually one of the reasons why we talk about looking at those 4 different measures, right? Because like you said, just letting someone out of jail, there's nothing there, and I'm not standing here saying that they should stay in jail, but we have to solve that other piece too. We can't, it's not, it has to be reducing the number of people in jails and making sure that they're in appropriate treatment and receiving appropriate treatment. Yeah. That's a great question.
So I think in our community, really this piece of putting this mapping together, which again, like Elizabeth said earlier, if you sign up with your email address, we'll be sending out the notes from earlier of what do we have in place in terms of housing and treatment and a plan, right, that would help someone have a place where they're going to have those right services because they're low risk and don't need to be in jail, so that's the goal that we're trying to achieve, is that someone would have a safe place to come out of jail and actually get to the next step support, some recovery and resiliency and wellness that NAMI, tells us we all should have, right? That's our goal as a community to have. So we hope that people will engage in this next step of our mapping. This is just like Elizabeth said, the first step, and we'll be working over the next several weeks to really put all these assessments in place and then develop a plan of how we fill the gaps and really have diversion at all the right levels. And again, the appropriate level of care for everyone. So with that, I'm going to close our public time. And again, we'll be here if there's any follow-up afterwards. And if anyone's joining us in beautiful Fort Bragg tomorrow, we'll be there to continue the discussion.